Hello, everyone. My name is Sienna, and I am the Chinese-speaking cancer patient navigator with Asian Health and Service Center. Welcome to today's August 2023 ACRSS Health Talk. Today's presenter is Dr. Michele Babicky. Dr. Michele Babicky is a surgical oncologist and hepatobiliary surgeon currently in private practice with the Center for Advanced Surgery at the Oregon Clinic. She's the medical director for hepatobiliary and pancreatic surgery at Providence Portland Medical Center and serves as the Hepatobiliary Fellowship Program Director. She received her bachelor's degree in chemistry from Villanova University and went on to complete her medical degree at the Keck School of Medicine at the University of Southern California. Dr. Babicky was a general surgery resident at the University of California, San Diego. She then spent 2 years as a complex general surgery oncology fellow at Memorial Sloan Kettering Cancer Center in New York City. Dr. Babicky has a strong background in basic science research with an emphasis on signal transduction pathways and immunology in pancreatic and bile duct cancers. Please help me welcome today's presenter, Dr. Michele Babicky.
Thank you very much for that kind introduction and for inviting me to speak today. Give me 1 second to, can you unshare? Yeah, there we go. And then let me share my screen here to get my slides ready. Okay, can everybody see that okay?
Yes.
Great. It's my pleasure to give this talk today. I've really dedicated about 20 years of my life to studying pancreas cancer. Was very fortunate to come to Portland, Oregon with the hepatobiliary group here and join some really amazing partners and join an amazing cancer center that's really doing a lot of cutting edge research and clinical trials to really advance the field for pancreas cancer. And so it's my pleasure to give you this talk today. I'm going to give a basic background of pancreatic cancer and then dive into some of the most recent research and clinical trials that are ongoing that are really starting to move the needle a bit in our field. I have no disclosures. And so to understand pancreas cancer, I think it's important to understand the pancreas. The pancreas is a gland that has both endocrine and exocrine functions, and I'll explain what that means. In terms of endocrine, it means it produces hormones that are important for metabolism, hormones such as insulin. And so these hormones are important for regulating your blood sugar, regulating your body metabolism. And they're secreted by these little islands of cells that have neuroendocrine cells in there that make hormones that are secreted into the bloodstream. And then there's an exocrine function, which is the rest of the pancreas, the majority of the gland, synthesizes digestive enzymes that are actually secreted into the GI tract. And this helps you digest your foods, particularly digest your fats. And so it's really, when we talk about pancreas cancer, we're talking about a cancer that arises in the lining of the ducts within the pancreas through which those digestive enzymes are secreted and how they get into the GI tract. And when we talk about pancreas cancers of the duct cells, we're talking about ductal adenocarcinoma. And so you'll see that terminology. And that just means it's a cancer arising in the cells of really the exocrine portion of the gland. And so just some pancreas cancer statistics. Pancreas cancer is really a rare cancer. There's about 64,000 cases of pancreas cancer each year in the United States. And about 50,000 patients a year will die from this disease. And it is really coming close. If you follow these lines, we've really seen some tremendous improvements in breast cancer, lung cancer, colon cancer, and the incidence and the death rates from some of these cancers are declining. But you can see the incidence of pancreas cancer is actually going up a bit, and the death rates from pancreas cancer have really remained stagnant to where they're starting to cross those lines. And it's, pancreas cancer is now the third leading cause of cancer death. So we have a lot of room for improvement in this disease, but I would argue that we are finally starting to make some progress. The important thing to understand about pancreas cancer is that it's diagnosed very late. So about 80% of our patients will have either regional or distant spread of their disease at the time of diagnosis. Pancreas cancer likes to spread to the liver, to the lymph nodes, to the lung, or to the abdominal cavity. Those are really the four major sites that pancreas cancer likes to spread. And it really has very few symptoms until it's more in its advanced stages. And while we're developing, newer screening technology and kind of studies looking at how we can catch this earlier, we really don't have any great test that is cost effective and really makes sense to screen patients for this disease. So it's very challenging. And that is really why the prognosis for pancreas cancer is so poor, because by the time we identify these patients, they already have very advanced disease. So there are some risk factors that have been identified for pancreas cancer. Some of these are modifiable and some are not. Modifiable risk factors include smoking, chronic pancreatitis, which can be due to alcohol abuse, diabetes, and particularly diabetes in association with obesity. These are all risk factors that are modifiable, but some are not. Our age, the older you get, the more at risk you could be for this. So our patients are typically over 70 years old. Gender, men are slightly more affected than women. Race, African Americans have a slightly higher risk, as well as having a family history of pancreas cancer. There are some genetic mutations that tend to run in families and can predispose you for risk factors for pancreas cancer. And there are some genetic syndromes as well that can put you at risk. Particularly in the Asian population, there is a slightly increased incidence of pancreas cancer in more highly developed countries. So you can see on this plot here, the incidences of pancreas cancer due to a higher life expectancy, particularly in Europe and in North America. There's a higher incidence of pancreas cancers because patients in those countries live longer. But you can see in the Asian population, it's kind of in the middle, with some of the Southeastern Asian and Central Asian countries being lower, really due to decreased life expectancy in those countries. So I've already mentioned some of the challenges to treating pancreas cancer. It's an older population. There's a higher risk of metastasis at diagnosis. And surgery for these patients is challenging. These are big operations. When we remove pancreas cancer, we have to do what's called a Whipple operation for tumors that are in the head of the pancreas. This involves removing the head of the pancreas, some of the intestine, the gallbladder, as well as the bile duct, which is the duct through which bile made by the liver drains into the intestine. And we have to reconnect all of those areas so that the pancreas and the liver and the stomach are able to drain adequately into the intestine. So that is a really big operation. And similarly, when we have lesions in the tail of the pancreas, we have to do what's called a distal pancreatectomy, and that involves removing the tail of the pancreas as well as the spleen due to the blood supply that it shares with the pancreas, and the distribution of the lymph nodes along, the tail of the pancreas going to the spleen. So these are big operations, and in older patients with multiple comorbidities, it can be a very significant and life-altering treatment course. So when we first identify a pancreas cancer and we're trying to determine the best options for treatment, one of the first questions we ask is, can we remove this tumor with surgery, or is it resectable? So when we say resectable, what we mean is that we are able to remove that tumor with surgery. And we really classify pancreas cancers into 4 categories. There are the patients, as I mentioned, with metastatic disease. In these patients, surgery is not an option if it has really spread outside of the pancreas to the lungs, liver, or abdominal cavity. In these treatments, the mainstay of treatment is really chemotherapy with a palliative intent to try to control the tumor and control their symptoms and preserve their quality of life as best as possible. But in terms of patients that do not have metastatic disease, they are really in what I call a better bucket, because there is the potential for removing those tumors with surgery. But we want to make sure that surgery is going to be helpful for these patients. And so we classify them into resectable, meaning we can remove it with surgery, borderline resectable, meaning that the tumors in these cases are often very close to critical blood vessels. And the morbidity of being able to remove those tumors with surgery is higher, and it's a riskier operation. And then there are the unresectable tumors where they are really encasing those blood vessels or extending beyond the pancreas in a very aggressive way. And so patients where it is easily removable, where it's a really tiny tumor, we caught it really early, those patients typically go straight to surgery and then are treated afterwards with chemotherapy. And in those cases, we really do think that cures are possible, particularly when we catch them early. The chemotherapy regimens, which I'll go over in a little bit for pancreas cancer, have really improved over the last couple decades. And we're seeing more responses. We're seeing, in some cases, patients with complete responses. And when we're able to get a good control with chemotherapy and remove them safely with surgery, those are really where we're seeing the best outcomes. But I do want to be realistic. This remains a cancer that is very aggressive and has a very poor prognosis. And so particularly for these patients where they have more aggressive disease, where it's really close to some critical blood vessels, those patients we try to treat with chemotherapy first for a couple of reasons. It makes the surgery safer because it shrinks those tumors up and improves our ability to really get the entire tumor out. And it helps us avoid doing big morbid operations with a high risk of complications in patients where we really don't get good control with chemotherapy. And if that's the case, then a big operation with complications is not going to be helpful. There is also a role for radiation therapy in these cases, because if we're having trouble getting a tumor off of blood vessels, and there's a chance that we might be leaving some tumor cells behind, it's helpful to treat these patients with radiation with the goal of getting good local control where the risk of the tumor coming back in that area is lower. Now, as I mentioned, the chemotherapy regimens for pancreas cancer really changed in the early, 2011, 2013 with the advent of FOLFIRINOX and Gem-Abraxane, gemcitabine and nab-paclitaxel that are shown here in red. These two regimens have never been compared head-to-head in a randomized trial, but they show similar improvement over what used to be the standard of care, which was single-agent gemcitabine, or in some cases gemcitabine with erlotinib. And these regimens have really changed pancreas cancer management in some ways, because as these regimens have become more effective, now the field has really moved towards pushing for chemotherapy up front in most cases, because as I mentioned, we shrink the tumors up, we're able to more easily remove them with surgery, and we're able to operate on patients where it's really going to be of a benefit. And then over the last couple of years, there's been the development of additional targeted agents for some subsets of pancreas cancer, where we've been able to identify different molecular DNA changes and mutations that are responsive to more targeted agents. And I'll show you some of that data towards the end of the slide. But it really is becoming, more promising. We're understanding more about the disease and trying to develop better treatments to help more patients. So there are lots of labs across the country doing really cutting edge research, and everybody's got their eye on pancreas cancer because it's really been a challenging cancer to treat over the years, and really one of the cancers that we've made the least progress. But there's a lot of exciting new research in terms of vaccines being developed against some of the known mutations in pancreas cancer, blood tests to be able to detect pancreas cancers earlier, particularly in patients that are at higher risk. There's an increased understanding of the genetic mutations in pancreas cancer. Most pancreas cancers have similar mutations, but there are ones that don't, and that have different targeted mutations that we can use different medications on. And we're understanding more about besides the tumor cells themselves, the way the immune system reacts to the tumor. And we're doing lots of studies on different ways to modulate your own immune system to be able to recognize these cancers earlier, and more effectively, and to really boost the immune system's response to controlling these cancers. And so lots of really exciting research in the field. So I thought what I would do next is go through some of the recently published trials in pancreas cancer, just to summarize some of the most recent data that we've acquired, and then I'll go through some of the existing clinical trials that we're currently enrolling. First was this study published in JAMA Oncology in 2021. This was looking at the role of chemotherapy before surgery in patients with resectable disease. So as I mentioned, the standard of care for patients who have really tiny tumors that we caught early is to take them out with surgery. But this was asking the question of whether or not giving chemotherapy before surgery, as I mentioned, we're really moving as a field towards doing that first, is safe and effective. And what they found was that it is safe and effective. This was really the first study that demonstrated that giving chemotherapy first in resectable disease is safe. They had a median overall survival of 23 months, which is comparable to what we see when we do surgery first and then give chemotherapy. And they demonstrated a 2-year overall survival of about 50%. And what was really interesting about this study is it really helped understand the challenges that we have in defining a tumor that is resectable. About 30% of these patients did not meet criteria for resectable disease after central review of their imaging. And I will say, pragmatically, in clinical practice, this is really true. We have a really hard time determining on imaging alone how easily their tumors are going to come out. And we often find ourselves in the operating room struggling to remove these tumors safely. And so anything that we can do to really maximize the success of a big operation is helpful. So this data was really helpful in kind of, again, pushing towards increasing the safety and the quality of our treatment algorithm and our surgical plan. There's also been some great studies, again, as I mentioned, looking at the molecular profiling to identify these rare tumors that don't quite follow the rules. This was a prospective industry-sponsored trial. They took patients' tumors and they sent them for molecular profiling. And patients that had actionable changes, so DNA changes or mutations that were identified where we had a known therapy or a known drug that could target that mutation, were eligible to receive that matched therapy. And what you can see in this red line here is that when we matched patients with that targeted therapy, their survival was 1 year longer than patients that were treated with that were unmatched and were otherwise treated with standard of care. So while they're rare, they're probably about 10% of pancreas cancer, so they are rare. But if we can find those patients that have a genetic profile that is slightly different than the rest, there are treatment options out there for them that could potentially improve their survival. And so that's where, the genetic testing that we have now for the tumors has become more cost effective and easier and more reliable. And so that's routinely run now on these pancreas cancers to try to identify alternative therapies that might be effective for them. Now, I have patients ask me a lot about the role of radiation therapy for pancreas cancer. And it really has been, the role and the timing of it over the years has been quite controversial. This was they recently published in 2022, the longer term outcomes of the PREOP-PANC trial. Their previously published results did not show a survival benefit for radiation therapy. This was a randomized controlled trial that compared chemotherapy plus radiation before surgery versus surgery first for patients with both resectable and borderline resectable disease. But you can see in their long-term follow-up, there was a slight advantage to the preoperative survival advantage to the preoperative chemotherapy, chemoradiotherapy, so with radiation compared to surgery alone. Now, the limitation of this study was that it was done with single agent gemcitabine. It was designed when single agent gemcitabine treatment was the standard of care. So this is not done in the setting of the more modern chemotherapy regimens that we use. But I will say that, we do use radiation therapy, particularly in cases, again, where I mentioned the blood vessels are really intimately involved with the tumor, and we're concerned that when we try to take them out with surgery, we may leave tumor cells behind. And that really, I feel, is the best role for radiation therapy. We do it selectively and kind of on a case-by-case basis. But it is, and we are really seeing some significant results with the newer technical ways that they deliver radiation therapy. They're able to manage the toxicity and really hone in the radiation therapy more specifically, and we're seeing better outcomes as a result. So still controversial and in evolution, but we're doing lots of studies to figure that out. And finally, I'm going to go through some of the ongoing clinical trials in pancreas cancer. This is the Alliance trial. It's currently enrolling, and this is really designed to try to understand better what is the role of chemotherapy before surgery in patients who have resectable, clearly resectable tumors on imaging. As I mentioned, that's the standard of care for resectable disease. But we know that about 50% of patients will not be able to complete their chemotherapy after surgery. You know, some of these operations to remove these tumors are big operations, their recovery is delayed, and their ability to really tolerate all of that chemotherapy after a big abdominal operation is limited. So this study is designed to give modern chemotherapy before surgery and versus after surgery, looking at endpoints of overall survival and quality of life. And this is a study we're currently enrolling. And as I mentioned, we're doing, more studies with radiation therapy. This is a really exciting BRCA2 trial that's currently enrolling for patients with borderline or locally advanced, meaning more extensive disease. And in this study, we're giving this experimental drug, which is designed to sensitize tumors to the radiation therapy. And we're comparing it with placebo-controlled, and both arms are getting SBRT, or a type of radiation therapy. And the endpoints for this study are overall survival, safety, and progression-free survival. And I will tell you, I've treated several patients who've been on this trial, and we're really seeing some great results. Tumors that, even when I started my practice about 5 years ago, we never would have thought we'd be able to remove. We've taken them to the operating room. And while it's challenging, in some of these cases, we've seen near complete responses. And I'm really excited to see the final results of this study, because these tumors that before would never come out are coming out, and it's really promising. Some additional studies. This is, one of the biggest challenges that we face in pancreas cancer is treating older patients who have very advanced disease. The newer chemotherapy regimens really are quite toxic, with a lot of side effects, particularly neuropathy, some numbness and tingling in their hands and feet, sensitivity to hot and cold foods and drinks. So this is a study looking at, it's a randomized phase 2 study looking at Gemabraxane, which is kind of our go-to. The side effects for Gemabraxane are slightly less toxic than FOLFIRINOX, versus this newer regimen, 5-FU based, which is a very common chemotherapy agent in GI cancers, based agent in patients with older patients over 70, trying to see if this is a more tolerable regimen for patients with metastatic disease. And again, as I mentioned, the influence of targeted treatments when you have a known genetic mutation. I think one of the most common genetic mutations we see are the BRCA1 or BRCA2, the breast cancer genes. These also convey a risk of pancreas cancer. And there's a great targeted agent that helps with the DNA, repair pathways that are mutated in these patients, called olaparib. And this is a study of maintenance treatment with olaparib after standard of care systemic chemotherapy and surgery in patients, looking at if we can prevent relapse in patients with these known targeted mutations. And I will tell you, I have a handful of pancreas cancer patients with these mutations who've been maintained on olaparib for a couple of years, and it has really given them good disease control. They do sometimes develop metastatic disease, but it's used as a maintenance therapy. And the endpoint for this study is relapse-free survival. So in summary, we are slowly starting to make progress in this very challenging disease. And this was very exciting. For the first time, we're starting to see an improvement in the 5-year relative survival rate for pancreas surgery. So we have multiple exciting lines of basic science research, as I mentioned, targeting the molecular mutations and the signaling pathways. We're continuing to work on early detection and surveillance strategies, particularly in high-risk groups, patients who have a family history of pancreas cancer, patients who have known, changes in their pancreas that put them at higher risk, and the use of liquid biopsies, trying to identify those DNA mutations in patients in blood tests to try to identify these tumors sooner. We're doing lots of studies on the interaction of the tumor cells with the immune cells, and trying to develop immunotherapy regimens and drug regimens that will help boost the immune system to fight these tumors. And as I summarized, we have several ongoing clinical trials looking at the role of chemotherapy before or after surgery in resectable and in borderline resectable and locally advanced disease, looking at the timing and the role of radiation therapy, looking at new targeted therapies in additional mutations that we're finding, and then optimal treatment for older patients with metastatic disease. So with that, I'll stop. Thank you again for the opportunity to present today, and I'm happy to take any questions.